record this. That looks like everything's working there. Cool. Alrighty. We ready to get going then? Hopefully. Awesome. Okay. So, any questions from last time on every other injection technique besides mandibular molars, or how are you guys feeling with that? Feeling like did any of that help? Was that useful? Yes, no, maybe?
Yes. Yeah,
cool.
Definitely.
Okay, cool. So I did this on purpose of, we're going to save mandibular molars because, as you can expect, they are the number one problem tooth that we have. Very rarely do we have issues with maxillary teeth, mandibular incisors, mandibular premolars, but the mandibular molars are problem children, as you guys can all understand. So why is this? They have a higher incidence of anesthetic failure because they're innervated by a bunch of different nerves. So you all know the IAN, the long buccal, the lingual. However, they can have accessory innervation. You can get it from the floor of the mouth, from the mylohyoid. You can get it from the back of the neck, from C1 through 3. You can get it coming down from the ear, from the auriculotemporal. And the other problem is you can't rely as much on diffusion because it is the thickest bone in the body. Think about when you do implants, you can load posterior, or actually anterior mandible, but you can load mandibular implants a lot faster than you can maxillary because the bone is more dense just naturally. So that leads us to having more failures and having to be a little bit more creative with how we get these people numb. So how many of you learned the difference between the direct and indirect techniques for anesthesia? Do you know what I'm talking about with that? Is this a new concept? You guys are like this small on my screen, so I need you to talk.
Yeah, new to me.
Yeah.
New to you? Okay, cool. So this is great. This is a technique that I'm going to send you. I'll text you guys a video after this, and I'll post it on YouTube as well. But the head of oral surgery at UOP made this video back in 2008 or 2009 that very accurately describes the difference between direct versus indirect. I'll do my best showing it here, but it's much easier having a skull. And actually, you know what? I do have a skull. I forgot. We added an oral facial pain specialist to our office, and she has a skull in the office, so I can actually show you guys here. So I might do that in a second. But as far as the direct versus indirect, we'll go in that in a little bit, but you want to make sure you pick up the lingual nerve. You all know how to do that. As you're going in, stop at about a 1/4 inch in, deposit a 1/4 of the carpule. That'll usually pick up your lingual nerve, no problem. And I recommend using lidocaine for this. There is many, many, many studies showing there's no benefit to using articaine for IA blocks. You do have that higher risk of temporary paresthesia, as we talked about last time. Same permanent paresthesia for all of them. So that's one thing to consider. But there's no difference in your anesthetic efficacy of using lido versus articaine for IAs specifically. So just use lido. As far as how this works, hopefully the video will work. Let me know if you guys can hear the audio or not. Otherwise, I'll just send this to you after as well. This is the last time I tried to put a video in because it's just not working. All right, so what we're going to be doing here is showing you the two different injection sites. So for an IA, what we're going to be primarily looking at, you can feel the edge of her mandible right here, and there's an indentation. And so for the direct IA, which is how most of you are probably taught, you're going to go right along where the canine is and come in at this direction right here, right where the raphe is. However, you don't usually see that. So I like to use the indirect technique. How we do that is we're going to pull her cheek back, and we actually go in this direction here and try to hit the bone. Once you hit the bone, you're then going to walk it along this way, and you actually get around the lingula, and you'll feel it drop, then bring it back to where the canine is and deposit the rest of it. The other thing is the injection points for the IA and the Gow Gates are slightly different. So your IA, you're going to be coming in right around here, and you'll see the angulation is angled kind of right up in this area. For the Gow Gates, you actually have to go all the way up here, so your angulation is going to be higher, and you're going to come in almost by where the second maxillary molar goes in, and go the full length up to where, kind of close to where the condyle is. Cool. Hey, the video worked. That's fantastic. So, just to show you guys using the skull, when we do this, hopefully you can see this okay. Let me get it in focus. Come on, focus. Ignore me. Pretty much there. This is backwards and left and right. Okay, here's where your IA goes in. There is this piece of bone on top of it. You can see me pushing against it. So the way that we were all taught is the direct technique. So you go in and try to just hit it perfectly like this. The much easier way is to deliberately hit the bone. This is so hard to do backwards and upside down. Deliberately hit the bone walk it back until it drops, and then it goes right on top of where the IA comes in, right where that foramen is. Does that make sense? Okay, I'll send you guys the video of the oral surgeon doing it as well, because that's how I learned to do it, and it is such a great technique. It makes a huge difference as far as your success rate. If I don't do this, I have a much, much, much higher risk of anesthetic failure and tend to have to go back and do it again. So that's what I'll say is this is a fantastic technique. It doesn't hurt the patients more to hit the bone. I know that's what some people will say. They usually don't feel it at all as long as you're slowly giving a little bit as you advance the needle, and it makes a huge difference as far as your success rate. So, all right, let's go back to any questions about that before I move on? No? Yeah. Cool. Okay, cool. Like I said, I'll show that. Oop, no. Stop it. God, I hate putting videos in the presentations. I'm so sorry, you guys. Okay, so just to show you again, these are the still photos of it. You're going to be coming in and you want to pretty much hit the bone on purpose. Once you hit the bone, and you can see the injection site's pretty much where it would be normally, kind of over by the canine. Once you hit the bone, you're going to then walk the needle back while still trying to advance it, and eventually you should drop down. You'll find patients who say, oh, I always have trouble getting numb. You almost have to go all the way past the teeth on the same side as the IA that you're giving because their bone is so large there. You have to walk around it, and that's why they tend to have more anesthetic failures, is because when the people have tried to give the direct technique in the past, the bone's just too big and it will stop you from getting it in there. If you're not within a millimeter or two of the IA, it's probably going to fail. That's how sensitive it is to the technique. And this is such an important injection for all of us because we deal with those hot lower molars all the time. Once you walk it back, you should be able to then feel as you're advancing that it drops down past the bone. Then walk the needle back over to the canine and deposit the rest of it. All right. Any questions on the IA? No? Good. Cool. All right. How many of you guys use Gow Gates on the regular? Remember, I can't see you. You guys are the size of a postage stamp.
On the regular, no.
On the regular. Okay. Okay. This would be another one I would recommend adding to your arsenal. So how I tend to do it, I'm going to give a traditional IA with lidocaine, and then I will go right in after and do a Gow Gates with bupivacaine. So the lesson from last time is everyone should be using a lot more bupivacaine because of the benefits of it. Remember, it has 4 times the potency of any of the other ones, as well as the long-acting, which helps with pain after. But the second thing I want to tell you all is to start learning the Gow Gates. It is a very, very, very useful injection. It's a very easy injection to give. A lot of people find that it's complicated. It really is not that hard at all. The benefit here is you're going higher up along where the nerve is, and not only do you pick up your IA, you usually pick up your lingual, and the BAM, which Emerald Lagasse would be very happy about, the buccal, the auriculotemporal, and the mylohyoid. That right there knocks out a lot of that accessory innervation that causes you to have anesthetic failure. So by just doing these 2 injections, it gives you a higher chance of success of getting the tooth numb. The reason that I use the long-acting and the more potent one on the Gow Gates is it's a similar injection. By the way, I got my appliance reinstalled yesterday, so I'm back to lisping. I'm very sorry if you hear me sounding like I'm a high schooler with a bunch of braces on. That's why. But the reason we use the Marcaine for this one is because it's going to keep more of these numb. It has a higher potency, and so you have a greater anesthetic success rate by doing it this way. And you want to do it after the Lido because the Lido and the Gow Gates have a similar kind of tract that you go along for the injection. And so by having the Lido first, you don't have as much pain from the acidic Marcaine injection. So very useful technique. I'll go through kind of how we do that. But the other thing to note, just as we talked about when we were talking about PSAs, you can sometimes, depending on the patient's anatomy, sometimes they will pick up, if you do a PSA, sometimes you'll pick up the IA as well. Same thing with the Gow Gates. Depending on their anatomy, sometimes you'll actually pick up the V2. So don't be surprised if every now and then when you give one of these, they say, oh, my ear's numb, my eye's numb, kind of my upper lip is numb. That's a normal thing that happens here. So for For your Gow Gates, the first thing you're going to want to do, we talked about proprioception last time. You're going to want to take your thumb, place it inside where your injection point is going to be, take your finger and put it right by the tragus of the ear. That's how far you need to go in. And the reason we do this is because this is a, we'll call it like a kind of an indirect technique of you don't have anything that you're hitting. You usually don't hit bone with the Gow Gates unless they have a giant lingula. But this tells you how far you have to inject. So on somebody like me who's big, you tend to have to go through the whole hub. On someone much smaller, you may only have to go in an inch or inch and a half. But by putting your finger there, you can feel how far it is from the distance of where your injection, where the needle goes in, until where you actually give the anesthetic. Does that make sense? Were you guys taught this technique when you learned anesthesia? Hopefully?
Yes.
Okay, cool. Yeah, it really does help to figure out where you need to go, because you don't want to go past it. That's not going to be good for anybody. All right. The other thing is the injection is going to be a little bit higher. So you're almost in the same plane as the second molar when you're giving this. So you're going to be aiming much higher, and you're still going to be kind of over by the canine, but it should be angled up superiorly. So you can see where the needle is going, right kind of up by the second molar, whereas your IA would be down here traditionally. And so there's your traditional IA, there's your Gow Gates injection. So if you've done this correctly, after you've given these two injections, you're going to see two little bleeding points about 1 centimeter apart. That's kind of where your two injection points are going to be. Any questions on Gow Gates? Start practicing these. I promise it's worth it. It'll help a ton with anesthetic failures. We'll go into all the accessory and all that stuff right there, but nailing these two is super, super important, so you don't have to do as many extra supplemental anesthesia. Do you guys have questions on any of these? If you think of them, speak up too.
Yeah, so with the Gow Gates, you're not as concerned with hitting the neck of the condyle or making contact with bone. You will every now and then, but if you look at the anatomy as you're going up there, there's nothing really in your way, because when you're doing that injection, you're coming in more hanging up at the neck of the condyle. So you're aiming up here, and there's nothing in the way. When you're doing that IA, here's the bone in the way, and that's what you have to get around. So for the IA, or for the Gow Gates injection, usually you're going high up enough that it's not a problem. And you don't find, so do you think that like making contact has any implication on whether or not block's going to work?
For the IA, 100%. For the Gow Gates, no. No. I mean, you'll find like those patients who tell you, hey, I have trouble getting numb, they will be more likely to have bone that you're going to hit. So every now and then, even on a Gow Gates, I have to walk over and do like an indirect technique. But I'd say 75% of the time, I don't hit anything on the way up. Whereas with the IA, 100% of the time, I try to hit bone.
Mm-hmm.
Yeah, good question. Any other questions, guys?
I've got one more.
Yeah, go for it.
So some patients with like, I don't know, like a big buccal fat pad.
Yeah.
No man's land, and I just let it go and pray.
Yep. And that's the problem with the traditional technique we've been learned, is that the traditional technique that we learn is that you look for the anatomical structures to know where to go. The problem with that is, what if there's too much fat in the way and you can't see those anatomical structures? Then you can't look for that little fold where you'd normally inject into. It's gone. That's where this indirect technique is so nice, is because you know if you hit the bone and walk it over, you're going to be at the right angle. Yeah. Any other questions about injections, guys? This is such an important concept for lower molars. If you nail these, the supplemental stuff is not nearly as important. Cool. All right. Long buccal, or kind of a local infiltration. We're taught to do long buccal because it picks up everything. If I'm working on a first molar, I'm going to give it right next to the first molar. If I'm working on a second molar, I give it right next to the second molar, because you're going to pick up what you need to pick up. And I don't really need to have everything numb. I just need the single tooth numb, and I'd rather have that concentration of septo right next to the tooth to have a higher chance of penetrating through the bone. This is one where we're always going to be using articaine because of the structure of it we talked about last time. It penetrates the bone more effectively. This has been shown time and time again. Don't use anything else for a local infiltration. Just use your septum. When you're giving this injection, you'll find that on older patients or really thin women, they have the exact opposite problem of they have no fat in that area. And so it's a very tender injection for them because the tissue is so thin. The way I found around this is if you grab the cheek and instead of poking it with the needle, have the needle there and lift it up into the actual needle. It's a much kinder injection. And I don't know if you guys have ever done it where you're giving the injection and all of a sudden there's just anesthetic flying everywhere because it's not inside the tissue anymore. This is a great way to prevent that by lifting it up into the tissue. Does that make sense? Are you guys familiar with this concept? Cool. All right. With these 3 injections, I found that on SIP-SAP cases, you get about 80% success. On necrotic ones, that's not a big deal, obviously. Retreat's not a big deal. But on any of these, let me shut this off. Sorry, 1 second. Okay. That should stop it, hopefully, maybe. 80% success rate at these points. So what do you do for the other 20%? Well, quite a lot. So as far as the options we have for supplemental anesthesia, we have a lot. So we're going to go through all of these, but all of these you're going to be doing with articaine because you want to have that penetration of the bone. That's usually why you're going to, no one's going to be going in and giving C1, C2 injections at the base of the spine. That's insane for dentists to be doing this. You need to rely on diffusion here and a few other different things. So we're going to go through each of these. Now, the very first thing you need to do is ask them, is your lip or tongue numb? Because if it's not numb, it doesn't matter if you do supplemental injections, the IA is not numb. So you have to get the IA numb. That's the first thing you want to do. So if you're noticing that the lip or tongue isn't numb, you want to redo the IA. When you're giving this one, switch to Marcaine or Bupivacaine, repeat it at the IA, don't repeat it at the Gow Gates, and you're going to not, you know how when you give the anesthetic, normally you're doing like a really slow, gentle amount as you creep it through? Give it like an oral surgeon. Hit the bone, walk it over, drop it all the way back, pull it, give it, and then deposit the entire cartridge right at the IA. Give it like an oral surgeon. Give it quickly, because you'll know in a second if you actually got the IA. If they're telling you their lip's not numb and you give this to them and they don't feel you giving a pH at 2 anesthetic super quickly, they're probably actually numb and there's something else going on. That tells you it's more supplemental. If they jump as soon as you start to give it, stop, give it gently, and then you'll realize, okay, I did miss the IA initially. So everything's a test. By doing this, if I have a patient come in and they say, oh, my lip's not numb, okay, we'll go ahead and give the bupivacaine injection with the IA. If they feel it, what I'm going to do is then, hold on, I got a cute little baby here. Yeah. Hi, honey. Here, say hi to the residents. Oh. Hi, residents. Say hi, residents.
Hi, Bunny.
Good job. Can you wave at the camera? Good job, honey. She's going to swimming right now, so she had a quick stop by and say hi. And we're going to see if she has second molars because they haven't come in yet. So we're going to go get an x-ray of that. But here. All right. Perfect. All right. Come on, Louie. Inside. Okay. Bye, honey. Have fun swimming. Bye, baby. I knew they were coming right on then. So, where was I? So we're using this as a test. And if they feel it, perfect. Give it a few minutes to soak in. You'll be good to go. If they don't feel it, then you know that it was something else. It was it was a supplemental innervation that caused them to have the anesthetic failure. And then you want to go back and give the other techniques. Does that make sense? IA's first, main priority. If it's not numb, do that. Once it's numb, then we can move to the next steps. I've seen a lot of people who they'll give one IA and then go straight to an intraosseous. I'm like, well, you probably missed the IA. Like, you gotta make sure that one's numb first. Then you can go to the other fun techniques. Okay. My next step every single time is what we're going to call a deep interdental. And so this is how the injection looks. It is a intraosseous injection. So you do want to let them know, you may feel your heart rate go a little bit faster, all the normal stuff you say with the epi. With the 1 to 200 septo, we don't seem to have as many issues with it. But this is definitely going to help you increase success. This is my first choice that I do. If the IAN is successful, this is my next step. When you're giving this, you want to use a short needle. I do recommend getting 25 gauge for these because since switching to 25 gauge needles, I haven't given an intraosseous, like a true traditional like drill hole, because there's no need. This stuff works so well. You're going to go in and angle kind of at a 45-degree angle coming down, just like you see in here. I go right in between the papilla, and I hit the bone. I give a little bit, and then I push a little bit harder, trying to get it to pop through that cortical plate, because it's pretty thin in this area. And you can usually pop through with a 25-gauge needle, and then you give it pretty much as an intraosseous injection. The beautiful part is once you get an intraosseous injection, as long as they're not super, super anxious, they're going to be numb because it bathes the entire tooth inside the bone, inside that medullary bone with anesthetic. This is a very, very useful technique. Like I said, this is I do these all the time. This is exactly the first step. As long as I know the IA is numb, this is what I do. After that, you have a couple different options. If they say, oh, my tongue's still not numb, but my lip is, okay, we can go ahead and do a combination buccal lingual infiltrations. And so you do a half carpule on each side. With septo, it has been shown to help with success. Pretty straightforward there. The mylohyoid is also a useful one. When I'm doing my lingual injection, sometimes I'll just pick up the mylohyoid. Have you guys been taught how to do the mylohyoid injection?
No, not extensively.
Okay, back to the skull. I'm so happy Sean is here. This is so nice that I have a skull. All right. Let me quick stop sharing again so you can see. All right. Your mylohyoid is going to run right down here, underneath that little bony crest right here. So when you're giving the injection, you're going to be coming in, you guys can see, kind of by that first molar, and you rub all along the bone and drop down about the length of a short needle and deposit right down there, because this is the attachment of the mylohyoid as you're coming along here. And so you want to go right down in that area, and that's where you're going to pick up the nerve. It is a weird injection. You want to make sure you aspirate here because there is a higher risk of having bleeding in the area, so make sure you're not in an artery because that's a bad day for everybody. But besides that, it's a very predictable one. The one thing I will say about it, where the hell is Zoom? There it is. Why is it not showing up? Sorry, guys. Oh, it's right here. Sorry, I'm looking at multiple screens here. The one thing I will say about it, it's a very painful injection. So if you are having failures and just do the IAN, this will pick it up. Your Gow Gates isn't going to always pick up that mylohyoid. I did like this diagram here because it shows you this is where you're going for the IA, for the Gow Gates. You pick up the auriculotemporal, you pick up the lingual, you pick up the mylohyoid as it comes down, and you pick up that buccal. So here's your traditional injection point for the IA. Here's your traditional injection point for the Gow Gates, and that's what picks these all up. When you give this injection, make sure they're already numb. Make sure that the floor of the mouth is already numb. So I'll give like a little bit next to the tooth. If they feel that, let it soak in for 30 seconds, a minute, and then do the mylohyoid, because as you're scraping along the bone here, this one they do feel. This is not a pleasant injection if they're not already numb, but pretty much you just kind of go down about 1 to 2 centimeters, depending on the size of the patient, and then deposit the anesthetic there. This one is useful. I probably give this one like once or twice a month. It's not a super common one, but it is a useful one to have in your back pocket. All right. The fun one, intraosseous. So the only one available right now is the X-tip on the market. Stabident used to be available, but they took that one off, unfortunately. X-tip is a little easier to use because it contains this little cannula thing right here. The Stabident, you drill a hole, pull it out, and then have to find the hole, which is sometimes tough because it's a pretty small one. The nice part with the X-tip is it leaves this little part in here, and it's very easy to then find it with the needle. Now, when we give this injection, it has a very high chance of success because, like I said, you're bathing the entire tooth in anesthetic around that medullary bone. It works extremely well. You do have to be careful with where you're giving this injection because you want to avoid the roots. They say that you can't get it to go inside the roots. I have proved that wrong, so don't be like me. Make sure you get that in the right spot. But a lot of people will say, oh, you want to use bupivacaine here because it doesn't have the epi. It has such a low success rate for it. Just use septo. Let them know. You might feel a little bit of that heart rate. I promise it's going to be worth it over having the pain of the anesthetic. Like just do it. Trust me. Let them know it's short. It's not going to last forever. It's the same sensation that they get when you give like 1 to 50 for Apicos. All right. How many of you heard of the single tooth anesthetic system, the STA or the pressure syringes? Anybody? These were big when I was in dental school. The whole idea is that it's kind of like doing an intraosseous PDL all in one. You load this cartridge up here with, you can actually put 2 anesthetics in there, and the assistants can change it out. So that is the one nice thing. If you want to give multiple carpules in the same spot, you can then adjust the flow and the speed for this sort of thing. And it's supposed to be less painful. It's still a needle and it's still anesthetic, so they still feel it. But it's you do have to be careful if you ever use this on the palatal. I've seen some gnarly cases where they just kept pushing, and because it has so much pressure, you can fill up the whole palatal and you actually get necrosis, and it's real bad. But as far as for our needs, what they found is it doesn't really make a difference. The one thing about it is it does have much better ergonomics. So the dentist I used to work for, he started to have a lot of carpal tunnel issues with any squeezing motion like this. And so the traditional anesthetic would cause a lot of pain for him in this area. The nice part about this is it's a pen. So when you're giving it, it has a foot pedal, and all you're doing is just pushing like you would with a pen. So for if you start to have wrist or any issues with that, this is a nice adjunct because it's not going to put as much stress on your hand. The one thing about it is pretty expensive. It's about $10 for all of the disposables per patient. So that adds quite a lot, and that doesn't include the cost of the anesthetic or the needle. So you are adding quite a lot of cost to seeing a patient, but if it's going to let you keep practicing and not have carpal tunnel, it's worth it. They have found multiple times that just using it instead of doing, like, there's a lot of people who be like, oh, just use PDLs instead of having to do the IA, because everyone's afraid of doing the IA. It doesn't work. Now, buffered anesthetics, this one is going to make some people angry. A lot of people really love buffering their anesthetics. It's this little cartridge that comes in here. You put your capsule of Lido, whatever it is, in there, put this in there. It injects all of this sodium bicarbonate, makes it so that the Henderson-Hasselbalch equation is on the side where you have more active anesthetic. It neutralizes the pH, which they need to keep it at for the preservatives, and makes it so that it's in the base form so it works a little bit more effectively, is all of the ideas of this. Now, when we test it in endo, what you see is there's no difference. This has been shown time and time again for SIP-SAP cases, which makes sense because there's not really a pH change. They still need to have a lot of anesthetic. For a lot of general dentists, when they're working on patients who aren't in pain, they do report less painful injections, and they do report quicker onset. So if you're a general dentist, buffered anesthetics do work, and they can be a better experience for your patients. As an endodontist, I don't see any reason to use them because all the studies show in the cases where we need the most help, that SIP-SAP on lower molars, it makes no difference whatsoever. The other thing about this is it is expensive. So I think it's about $10, I think, to do multiple cartridges of it. So it's definitely adds to the cost of seeing the patient. However, if you're going to be in a big city and need to make yourself stand apart because you have a lot of competition, this could be something you advertise for patients of, oh, we make the anesthetics even less painful for the injections by using this on pharma kit or whichever one you want to do. And that's an advertising thing for patients if you're in that area. And it may help via placebo effect of patients thinking that it's going to be better. So just a concept there, but it's not something I own. It's not something I'm interested in doing because it doesn't seem to make a difference based on all the studies. All right. How many of you heard about Tuttle Numb Now? Anybody?
Yeah. Yep.
Yeah. This is a dentist who tried to copyright a technique, which isn't a thing. And just for any lawyers watching out there, I have not actually purchased his thing. I learned about this at an AA meeting from somebody who specializes in anesthetics. So I'm not stealing his things. I'm just reporting what somebody else told me. Trying to cover myself because this will go onto the internet. How it works is you're going to use this special needle, and the special needle is a little bit sharper on the end, so it's the Septojet Evolution. They are really cool. Once again, More expensive, unfortunately, but it does work pretty well for those deep interdentals as well because it's a very sharp needle on the end, which allows you, when you're rotating back and forth, to do it. And that's pretty much the technique. It is an intraosseous injection, and what you're going to do, do I have the bending it? Okay, you have this little cap that goes on top of there, and you bend the needle. What you then do is go in, like as a PDL or interdental, and as you're pressing, you're going to start doing this rotation motion back and forth, back and forth, back and forth, while pushing on this blue part and expressing at the same time. So you can see it's kind of a weird multi-handed thing that you have to do. Eventually, because of the needle and the pressure, you're going to pop through the cortical plate and then be able to give what is a pretty much intraosseous injection. The benefits of this, according to Dr. Tuttle, are you get them numb instantly, which in the intraosseous injection will get them numb extremely quickly. And it's supposed to be less painful. I don't know about that. I don't know if I'd really want to have somebody cranking back and forth on my tooth like that. And if you're going to be doing this for endo, just use a 25 gauge needle and pop through. I promise it works really, really well. So you don't need to buy his $30 technique because there you go. That's what it is. All right. Intrapulpals. This is great because they work 100% of the time, but you have to have access to the tooth. So if you haven't dropped into the pulp canal yet, or the pulp chamber yet, this is where, okay, what are you going to do? You may have to take the rubber dam off, keep doing supplemental injections until they're numb enough that you can drop in. Because once you dropped in, you can give intrapulpal injections. It does not matter what you give this with. You can give it with water. They've shown this in multiple studies. It is pressure-based anesthesia. It's not from the local anesthetic itself. It works 100% of the time. The problem is it only lasts for about 30 seconds. So once you've accessed the pulp, you're going to take a 30 gauge short needle. This does have to be tiny because the pulps really are too small. That's the one issue I found with using those 25 gauge needles is they're just too big to fit inside the actual pulp canal. So I now keep 30 gauges specifically for intrapulpals. You're going to push. You only give like a stopper because that's all that you can really get in there. And the important thing is immediately go in with a rotary file. You want to rip that nerve out as quickly as possible as soon as you get them numb because it only lasts for about 15 to 30 seconds. So when we're going to give an intrapulpal, we warn the patient, you're going to feel a lot of pressure, then you're not going to feel anything. I do apologize. This is the best way to, you can say your nerve is really upset. You can say, I usually use an analogy of your tooth is really inflamed, which means there's a lot of pressure and bleeding. It's literally pushing the anesthetic out of the area. We know that's not the case, but patients kind of understand that, and then I have to go right back in there, and then we'll get the nerve out. Once you get the nerve out, they usually don't feel anything the rest of the time, and it's interesting. On multi-rooted teeth, it's usually just one of the canals. That's the problem. I find that it's whatever, like, if the caries is closer to the mesial, it tends to be the mesials that are the problem. If it's closer to the distal, it tends to be the distals, and the other side isn't the problem. So it's only in those SIP-SAP cases where you really see this as a big problem, and it usually is only one of the roots, but very, very useful technique. Okay. Then there's the question, when do we give up? If you see the patient is visibly anxious, we can go back to that amplifier analogy. I don't care how many injections you give them. You're not going to get them numb. They are way too ramped up. There's nothing you can do to actually get them numb. If you see them shaking, if they've sweat, like I have a big gown, a plastic cover that goes all the way down to their knees so you don't get bleach on their clothes. If you see them sweating through that, it's time to stop. If you see their eyes are this big and they're terrified, it's time to stop. Bring them back on drugs. It's worth it. My number is 6 carpules. Really, it's 4, but I tell patients 6 is my max. And that's because, if you remember from last time, the maximum amount you can give is based on the lowest amount of the whatever anesthetic you're giving. Articaine is 6.5. So after 6 injections, that's my regular 3, plus usually a full thing of PDLs, plus a thing of Buccal linguals, and then maybe some more. Maybe I'll go to intraosseous. But at that point, you've given enough. You can usually tell this patient is just, they need to come back on drugs. And that's usually what I'm going to do. So I'll talk to the patient. I'll use that amplifier analogy from last time. Make sure you don't shame them. Let them know, I get 1 or 2 of these this month. You're my first one. Doesn't matter how many of these you have. If you get more than 2 of these a month, call me and we'll go over, IA techniques, because you shouldn't have more than a couple a month where you have to give up. Let them know it's not a big deal. You don't charge for the sedation. They just have to have someone take you. It's totally normal. It's not a big, make sure that they don't feel like that they're wasting your time, and that it makes a huge difference. Because for a lot of people, they're hiding their anxiety because of shame. I see this a lot with guys. Most men who are afraid of the dentist hold it in, and then tend to lose it as soon as the rubber dam gets on, which is perfect timing. They all of a sudden you're like, oh, you were really anxious. You were just good at hiding it. So make sure you don't shame them when talking to them about this. Bring them back on Trazlan. We'll talk about it next time. On adults, I use 0.5. Kids or the elderly, you want to drop it down a little bit. But on these patients, you need to give them the higher dose. You need to get them knocked down because they're going to be, even at the next time, you may find that they are still talking to you just as you and I are right now, and they won't remember a single thing, and they'll be a lot easier to get numb. It's crazy how different people react. All right, little bit on nitrous oxide. So yes, it is the same stuff as from the Fast and the Furious, but when we give it to humans, it has a couple cool effects. Number one, it is incredibly safe. Every nitrous system now has a built-in fail-safe where it will not let you give less than 30% oxygen. If you remember from the breathing episode, we are currently breathing in, depending on your altitude, anywhere from about 19 to 22% oxygen. So you are giving them almost a third more, a half time, 50% more than what they used to have, even if you max it out to the highest percentage. It has both analgesic and sedative properties. If you guys remember the story of how this was initially discovered, they were having nitrous parties where they would, pretend they're getting a big thing of galaxy gas and blowing up balloons, and this guy would come to town and they'd all get high on nitrous. And he noticed that, it was actually, I believe it was the dentist in the audience, noticed that one of the people who was high on the nitrous cut their leg and didn't feel it. And so this is before we were using local anesthetics, and so this is where nitrous and dentistry all came together back in the late 1800s. So there's your fun history lesson for the day. The beautiful thing about this, it's quick on, quick off. They will start feeling it after a minute of breathing it. After a minute of breathing oxygen, they're back to normal. How this works is through the NMDA receptors in the CNS for the anesthetic. For the analgesic, it works through the opioid because everything works through the opioids. And for the anxiolytic properties, it works through GABA. So it has really great effects. What I found, though, is if the patient is old enough that they consumed alcohol, usually it's not going to work as well. That's just kind of the rough, most teenagers, when you start to lose it a little bit, works great on children, works great on preteens. Most adults, though, it doesn't really have the effect. And if I'm going to be seeing them, I want them to actually be down so I can get them numb and do the treatment. And so I tend to use Halcyon. I maybe use nitrous once every other month at this point. We have it because the oral surgeon uses it for all his sedation cases because it allows him to not have to give as much of the other drugs. But I tend to use it very sparingly. It's only on patients who are like, I want the nitrous. I know it works. Cool. That's great. We'll use it for you. But otherwise, if you're building an office and don't have nitrous in there, is it worth putting in? Probably not. If you already have access to it, offer it. But I would much rather use Halcyon most of the time. If you are going to use nitrous, however, this is the best invention of the last, I don't even know how long. This is called the Silhouette nose mask. That's how low profile it is. It's incredible. So as you can see, you can put a rubber dam on top of this, no problem. Sorry guys, I'm getting over a little cold too. And it has so much more space. So that traditional nasal hood that's like this big on top of them, they look like they're wearing a Bane mask, makes it really difficult to do the root canal. These things are fantastic. They are a little pricey, but it's totally worth it if you're going to be doing it. They just have a little adhesive in here that goes to the side of the nose, and then you have the exhaust port and the in port. It works super, super, super well. All right. We actually did pretty well. So, as far as the summary, we're going to conclude stuff from last time. You want to use non-pharmacological methods whenever possible for anxiolysis. A lot of this comes down to how you present yourself and how you communicate with your patients. Make them feel safe. That psychological safety is such a big thing. We are all hairless monkeys running around. This works on all of us, I promise. You're special just like everyone else. Makes people feel that they don't have shame for being special, that they understand that this happens and that you are there to take care of them. Distracting them by doing the cheek shaking, visualization, getting them breathing. It makes such a huge difference in your effectiveness. And it's things that you don't think of, but really does make a difference with them. If you're going to be giving the local anesthetic, or when you give local anesthetics, make sure you use benzocaine. The placebo effect alone is worth it, and it makes people feel like that psychological safety's in there. I use the combination of Lido, bupivacaine, and articaine. I have really good success rates with all three of these. There are lots and lots of different ways to do supplemental anesthesia. I've given you mine. Figure out your favorite ones. Some people don't want to do PDLs. Some people love using intraosseous. Pick your poison. They all have a benefit. When you first start off, you're going to want to be a hero to so many of your patients, and make sure that you get them in and get them for treatment. And I made the same mistakes. It took me a while to realize if they're not having a good time after about 3, maybe 4 injections, just bring them back. It's not worth it for anybody. They're not going to get numb. They're going to jump the entire time. It's going to be terrible. I did laugh after our last lecture. Right around the election, everybody was having problems getting. It's clear that the anxiety around the election made everybody more just turned up. I was giving so many supplemental injections 2 days before and 2 days after. It was absolutely insane. I had so many just crazy bleeding cases from inflammation that week. So it's interesting how the environment and what's going on in the country can actually impact your ability to get your patients numb. Nitrous is really useful for kids. Hit or miss for adults. Most of the time for adults, I'm going to use benzos. One thing I forgot to mention about nitrous, which is really cool, is it has a time dilation effect. So it makes 30 minutes feel like 15 to the kids. And so you can often say, we're going to be in here for about the time of a cartoon. And they understand oh, I can sit still and watch a cartoon. And even if it takes you 30 minutes, 45 minutes to do the treatment, because they're on the nitrous, it will feel like it goes a lot faster for them. So that's one of the other benefits of nitrous. Okay, we are all good there. All right. We have a few minutes for the super fun Ask Me Anything. Let me quick see if my patient's here. What was that helpful for the anesthetic stuff? I know that's a lot, but it's such an important part of what we do. Oh, I'm good. No patients here. Good. It's such an important part of what we do, and it makes a huge, huge, huge difference for these patients to have that feeling that they are numb, that they're not going to feel anything. Root canals are boring, you guys. I specialize in boring root canals. The way you make them boring is you make them incredibly numb, and they don't feel anything. I mean, the number of times I hear, that's the most numb I've ever been, great. That's exactly what I want to do. So, what questions can I answer for you all?
How long do you wait for an IEN to set in?
About 5 minutes. Yeah. At that point, they should be numb at that point. More time isn't going to really give you much. At that point, if they're still feeling it, I will. Good question. So if, let's say, all right, 5 minutes, the assistant goes in, cold tests, and they still feel it. There's 2 very different responses. There's they hold it there for, 10 seconds, 15 seconds. Oh, I think there's something right at the end. On that one, give them another 2 minutes. They probably just need more time for it to soak in. Not a big deal. Versus you test it, they jump out of the chair. Okay, clearly they are not even close to getting numb. You need to go in, and that's when we start asking the questions. Is your lip numb? Is your tongue numb? Okay, if that's not the case, we're going to be doing another IA. Oh, wait, your lip and tongue are numb? Okay, cool. We're going to go to PDLs. And I've taught my assistants to ask these questions, so I don't have to ask them. And when I walk in the room, the right anesthetic is in there. So if they know that the lip, if the lip and tongue isn't numb, okay, he's going to redo it with Marcaine. Oh, if the lip is numb, but they're still feeling it super fast, okay, he's going to need a shortened septum. What other questions?
Can you decrease the dosage of Halcyon for younger patients and elderly? You just have it?
Yeah. This is a complicated. On anyone over 65, your maximum dose is supposed to be 0.25. And sometimes that works great. Sometimes they still are absolute messes. So if you talk to any anesthesiologist, sedating anyone over the age of 60, 65 becomes a little bit more complicated because sometimes they need more, sometimes they need less. It's kind of tough. So I generally ask them, if you have a headache, how many ibuprofen do you take? And if they're like, 1 and I'm great, cool. you can probably get away with 0.125, maybe 0.25, depending on how bad they seem. If they're like, I take 6 of them, I'm like, okay, well, that's bad for your kidney. Don't do that. And you're getting the big dose. On kids, I do it a little bit more off of weight and how bad they are. So generally, anyone over 100 pounds, you can give the 0.52, no problem. Anyone under that, it really depends. I'll often like do a test. So on all my pediatric patients, I see them for a consult first. And during that consult, I'm kind of testing, okay, how well do they sit in the chair? Are they doing this the whole time? Are they bouncing around? Are they looking at everything? Okay, they're going to probably need a higher dose. What will they let me do? So I had one yesterday where I had to put a bite block in just to put SDF on his tooth. And he was screaming during that. Like, okay, if we need to do this, the dental anesthesiologist is coming in. I'm not even going to waste my time with normal stuff because they need so much more. And that's where oral sedation is more complicated because it doesn't work on everybody. And it's very difficult to titrate because it takes time for it to come in. If you are working on an elderly patient and you're not sure what to do, what I usually do is have them take 1.25 an hour beforehand, bring the other pill with them to the appointment. See how they're feeling. Sometimes they're great. Sometimes they're like, I feel completely normal. Cool. The way you can get it to kick in really quickly is you crush the pill, dissolve it in a little bit of water, and have them hold that underneath their tongue, and it kicks in about 5 minutes where they start to feel it. So it does work a lot faster if you crush it up and put it in a little bit of water.
Do you find, I feel like we've heard mixed things on whether or not they should be taking that first dose the morning of or the night before?
Ooh, great question. Yes, we'll get into this a little bit next time with the pharmacology, but the idea being, why do you think we have them take it why do you think we have them take it the night before?
So they get a good night's sleep so they're not as anxious?
Exactly. It's because if they don't get a good night's sleep, if they're that bad that they're worried about seeing you, well, they're probably not going to sleep that well that night. And then they're going to be an absolute wreck when they get in there because they only slept for 3 hours. And now you're going to be doing this scary thing to them. So it's probably not going to work. So you can kind of judge based on how anxious they are. One thing I will say, we'll talk about this next time too, but if a patient is not benzo naive, like if they're on chronic Xanax, I find that Halcyon doesn't work that well. In those cases, I'm going to switch over to Ativan and do it exactly as you said. We're going to do 1 pill an hour before they go to bed, and then 2 pills 2 hours beforehand because it does take a little bit longer for that one to kick in. So most of the time, if it's an anesthetic failure and you don't think they're that bad, you can usually get away with doing 2 an hour beforehand. If you're really concerned, do 1 an hour before they go to bed, and then make sure their appointment's first thing in the morning. Because Halcyon doesn't have that long of a half-life, so it'll still kind of be in their system. It kind of primes the pump to accept more, and it makes them a little more sleepy. Good questions. Have you guys done any cases with Roxanne yet?
I was supposed to do one this afternoon, but I think that's more a patient problem other than Halcyon problem outside of.
You'll find there's a strong.
He showed up at the appointment at 1 p.m. with both of the pills in his hand, and I was like, "Thank you, sir."
Yeah. When you get into private practice, I can send you guys a template if you want, but we have a sheet that we fill out for them. We literally write on there, your appointment is at 1 p.m. You are taking 2 pills under your tongue an hour beforehand at noon so that they don't have as many opportunities to, yeah. It's, once again, learn from me. I've made these mistakes as well. So good questions. Hopefully it works out, but, they better be taking it now if it's 1. Everybody here already been taking it, so. Any other questions, guys? Hopefully that local anesthetic one was good. I think the pharmacology one will be helpful as well. I'm not going to go into the full pharmacology that you guys get from SLU. I'm going to just talk about the drugs that you're actually going to use in practice and kind of how to use them and some things around that. But any other questions?
No, thank you so much.
Cool. Go have a good one. I'll see you guys in a couple weeks.
Thanks.
Okay. Bye.